Now the next topic is trauma and anesthesia. All anesthesiologists, day in and day out, administering anesthesia to the patient, but giving anesthesia for elective case and in a trauma patient, there is a hell of a difference due to altered physiology and erratic hemodynamic changes due to trauma. This new reference focuses on a broad spectrum of traumatic injuries and the procedures anesthesiologists perform to adequately care for trauma patients. Management of polytrauma patients has advanced and improved over the last few decades with a better understanding of pathophysiology of shock, resuscitation, and hemodynamic changes. Anesthesia and application of anesthetic principles have consequently evolved and can be applied in polytrauma. Today, we will be discussing topic trauma and anesthesia, and I am sure and confident that will provide insights and perspectives on this important subject. I am sure that this interaction with our speakers will be valuable learning experience for all of us. I would like to call Dr. Deepali Thakur Madam, and I would also like to call Dr. Hemani Madam, senior practicing anesthesiologist since 1982, from geriatric to pediatrics and labor analgesia to block, to chair this session. I would also like to call Dr. Manohar Mane, who is a former professor and PG teacher, Bharati Vidyapit Medical College, Sangli, completed BLS and ACLS instructor course and having special interest in cardiac anesthesia. I request Dr. Hemani Madam to briefly introduce our speaker, Dr. Thakur Madam.
Good morning, still it is a good morning. I am really happy to announce a very young, our anesthesiologist, Dr. Deepali Thakur. She is Associate Professor at Department of Anesthesia, LT MMC Sion, Mumbai. She is MBBS, MD and PGD HHM. Her area of interest is difficult airway, trauma and intensive care. She did multiple publications in international and national, including original articles and cases reports. And she has written a chapter in current practice in emergency anesthesia. I really most welcome Dr. Deepali Thakur on stage.
Thank you very much, madam, for that kind words of appreciation. First of all, thank you so much, organizing team, ISA, MIRAJ-SANGLI, for inviting us for this lecture and allow us to share our experience from the city of Mumbai. So, since today we have dedicated ourselves for insights about trauma, I will be throwing some light about the interactions of this trauma and anesthesia. We as anesthesiologists, I believe, A stands for anesthesia, analgesia, and A also stands for airway, A also stands for anticipation. The anesthesiologist who can anticipate what your patient is going to have, what problems your patient is going to face during perioperative period is, I feel that is going to be a successful anesthesiologist, and he will be facing and managing the problems more efficiently. So, to start my topic, Dr. Manish has already discussed about the mechanism of injury and the details about the trauma, the rise of trauma accidents in our city and globally. What is more important is it is affecting the all age group population. Mainly it is affecting the young and productive age group people. However, pediatric trauma and geriatric trauma is not an exception. So we in our Sion hospital, we do get patients from all age groups with all comorbidities, okay? And when we are in scene of these trauma wards or trauma, mortality becomes a very important subject, and identifying the early preventable deaths is where we come in picture. So what is the role of anesthesiologist? To summarize, we can be helpful in pre-hospital care and transport of patients. We can be a trauma team member in emergency department. We can provide anesthesia services, part of operation theatre team. We also have a trauma intensive care role in perioperative management and as a pain physician in acute and chronic pain. So our role is not only limited to inside the OR, right from the trauma, the injury, the event where it has happened to pain is the wide spectrum where we can interact with the patient. So I will be covering the ATLS approach has been wonderfully covered by Dr. Manish. I will be covering general principles of anesthesia, post-operative care and some special trauma concerns in special injuries. So knowing the etiology of trauma is very, very important. Why? Because whatever may be the mode of injury, you have to anticipate the type of injuries depending upon that. So at scene, what you will see, you may not have any investigation in your hand, but just by knowing the mechanism of injury, you can anticipate what your problem is what your patient is going to face problems during hospital stay. Injuries can be isolated. However, polytrauma and combination of multiple injuries is not a rare incidence. So do remember, a patient with pneumothorax can come up with head injury. He can have some limb fractures. So detailed ATLS sequential evaluation and management as per primary survey, secondary survey with ongoing resuscitation is the mainstay in trauma care. Whichever level you are interacting with the patient, wherever you are coming in contact with patient, this sequence has to be followed simultaneously. So what these patients can come up to us for surgeries. There are certain emergent surgeries and there are certain urgent surgeries. Mainly we will be interacting in this particular duration. However, these patients will also keep on coming for repeated surgeries. So non-urgent surgeries but repeated fracture fixations or debridements, they will keep on coming to us again and again. So this is also important to keep in mind, that what is the time of surgery where we are evaluating the patient. Depending on that, the principles will vary. What are the concerns? Because these emergency procedures, life or limb threatening procedures occur at odd hours, inexperienced personnel may be dealing with the case. Resource availability may be a problem. Equipments are available with the institute, but they may be in lock and key, not available for the juniors, mainly airway equipments. Limited patient information, because many a times no relative is available, patient is not in condition to give you history, so you know nothing about the patient. Patient may be intoxicated, he is to be considered full stomach. Cervical spine instability should not be forgotten. And patient may have multiple injuries, so requiring complex positioning, supine to prone to lateral, any position will be required, and multiple simultaneous surgeries may be happening on the patient, and chances of occult injury is not to be forgotten. So coming to pre-anesthetic history, ample history is must. Wherever possible, please do interact with the patient about allergies, addictions, what medications these patients are, especially geriatric population. They will be on polypharmacy, they will be on beta blockers, antiplatelets. So your plan of anesthesia will vary accordingly. Past medical surgical history in childbearing age group females, you should be asking about LMP and pregnancy status, last meal intake, and details about event or environment related to the injury is very important, like in burn injuries or chemical inhalations. It is important to predict the airway edema. Physical examination mainly should focus on primary and secondary survey with main focus on airway and important systems. Available lab investigations along with fast reports, C-spine or CT MRI reports, make it a point to see what the injury, what is the severity of the injury. Coming to airway management, a favorite topic for all our anesthesiologists. In trauma, it is little different from what we manage on elective basis. Remember, all these surgeries are, I am talking about emergency surgeries. So the airway is not only anatomically difficult, it is physiologically difficult. Patient may not be in an optimal state of resuscitation and you are dealing with the airway of this patient. So that makes the patient more prone for hypoxia. So do no harm and prepare and practice when you have time. So for elective cases, whenever you have time, you have to practice with your newer gadgets. You should be familiar with the newer techniques like video laryngoscopy. Never take away anything you cannot replace. Suppose patient is spontaneously breathing, without judging or having a complete idea about the patient, do not give muscle relaxants in hurry. So intubation can be difficult in cases where you have facial fractures, oral bleeding, disrupted airway. Urgency of intubation, you may not be well prepared for that intubation, and patients are always all trauma patients are to be considered full stomach otherwise. Patient intubation can become dangerous if patient is having head injuries, unstable cervical spine injury, patient is having hypovolemic shock, and multiple unsuccessful attempts can lead to hypoxia and airway injury, which is to be avoided at any cost. So, quick airway assessment, difficulty of bag mask ventilation, we have mnemonics, moans and bones, difficulty for laryngoscopy, Lemon assessment, ATLS has recommended Lemon assessment for predicting difficult airway in trauma patients. What is more important is difficulty in surgical airway access. Very, very important, because that is your plan D for trauma intubation. So cases where you have difficult surgical airway, you should be alarmed that yes, I have to go in my stepwise manner. Your plan A, plan B, plan C has to be properly predetermined in your mind. So that's about the Lemon assessment to predict the difficult laryngoscopy. Cervical spine injury patients can have disastrous complications during airway management. Usually these patients present with bradycardia, and patient may have some neurological deficits. You have to suspect cervical spine injury in high-speed impacts, multi-system trauma, altered level of consciousness, and blunt or penetrating trauma above the level of the clavicle. So whenever you suspect, you may not have a radiological proof or a CT scan, but upper cervical spine injuries like C1, C2, here you can see C1, C2 atlantoaxial dislocation, and here you can see a significant anterolisthesis of C2 over C3. Luckily the cord is well preserved. This patient we had in spite of having such a bad injury, this patient was not having any neurological deficit. So these are the patients where your airway management skills will determine the morbidity post-operatively. So assume cervical spine injuries until it is cleared radiologically or neurologically, and we have to consider that while managing the airway. The airway management protocol, as per ATLS, we are following the airway BLS skills. Oxygen, very important. It has to be considered as a drug, and it has to be administered to all the patients of trauma during the different phases of resuscitation. Airway management, mainly it is rapid sequence induction or modified rapid sequence induction or drug-assisted intubation. We will come to that in detail. What are the indications? Where all you will require to secure an endotracheal tube? Endotracheal tube, whenever you are considering adult patients, always go for cuff endotracheal tube, because we are considering all the patients as full stomach, okay? So, unstable mid-phase trauma patients, airway injury patients, apneic patients with flail segment or patients in respiratory failure, class 3, class 4 hemorrhage, hypotension, Glasgow coma, GCS score of less than 8, high aspiration risk and inability to maintain oxygenation or airway. These are the rough indications for tracheal intubation. Coming to cervical spine stabilization, usually you will see a patient with cervical collar in place. your intubation and airway management is going to be difficult because of presence of this collar. So the anterior part of the collar you have to remove when you are doing a bag mask ventilation or you are attempting an intubation. And malunilline stabilization is must. Either you can give it from below as in second picture, or you can give it from above, stabilizing the neck during the attempt of ventilation and laryngoscopy. This skill has to be taught to all the postgraduate students, and we have to practice this because you do not, most of the times you do not know the severity of the injury. And as all these intubations, the patients are full stomach, so we are also maintaining a cricoid pressure during the attempt. So being prepared is always recommended for these emergency airway managements. Knowing your equipments, functionality of your equipments, whether the batteries are changed, whether the cuffs are okay, that has to be done when you are preparing your airway cart. Correct size of equipments, as you may get a patient from pediatric age group to geriatric age group. So correct size of endotracheal tubes or LMAs is must. Let me remind you all that we have intubated adult patients with 4.5 number or 5 number uncuffed tube in case of severe airway edema following burns injury or inhalation injury. So one set of all sizes of endotracheal tube, one set of all sizes of supraglottic, preferably second generation supraglottic airway devices should be a routine part of your airway cart. Familiar technique. Why I am saying this is you are not going to use any new technique in this emergency trauma patient. You have to use the familiar technique in case of emergency scenarios. So video laryngoscopes, they have made the life of anesthesiologist very easy, especially for difficult airway, elective difficult airway. But in emergency difficult airway management, there may be some problems when patient is having bleeding, excessive secretions, or patient is having oral trauma. In that situation, the vision is not going to be good. However, it has been incorporated. We are using video laryngoscope routinely wherever we are anticipating difficult intubation, and it gives an excellent view of enlarged view of glottis, and the assistant also can help in intubation. So you have to, as a PG or as a anesthesiologist, we have to master this skill for our airway management. Fiber optic or flexible video endoscopes, these are also we are routinely using in our semi-elective cases. However, prerequisite is patient has to be cooperative and a skilled operator has to be available. So this technique, again, it may fail in case of oral or nasal bleeding. Patients who are unstable, hypoxic, you cannot try this technique. So difficult airway algorithm which is modified for trauma. What are the salient points is oxygenation has to be continued at all the stages. Cancelling the case and awakening the patient is not the option over here. So surgical airway may be the first and the best option in certain scenarios. Awake techniques only for stable and cooperative patients and spontaneously breathing patients, and ETCO2 confirmation is must to avoid accidental esophageal intubations in emergency scenario. Extubation wherever you are anticipating airway edema or wherever you are anticipating difficult extubation, please use airway exchange catheters, or you can extubate over fiber optic guidance. So ATLS has simplified the protocol for trauma airway management. Being prepared, we discussed that your airway cart has to be always prepared, always be prepared after every intubation. It is not daily, it is after every intubation you have to replace whatever is being used. So oxygenation, a big stress on the oxygenation. Even the IDA 2016 guidelines are stressing on the peri-procedure oxygenation by nasal oxygen. 10 to 15 liters is to be continued throughout the procedure, throughout your attempts of intubation. So when the oxygenation is not possible, so here you are directly going for a definitive surgical airway in trauma. Wherever oxygenation is possible, assess the difficulty of airway as per Lemon criteria. If you see that there is no difficulty, you can proceed with intubation, either drug assisted depending upon the hemodynamics of the patient, drug assisted with cricoid pressure. And if it is a difficult airway, then call for additional help, preferably a senior person should be involved. Difficult airway techniques like whatever is available to your institute and whatever you are comfortable with, the awake techniques and adjuncts are to be used. In adjuncts, we have multiple options like bougies, videolaryngoscopes, intubating LMAs or supraglottic airway devices, combi tubes, laryngeal tubes, anything can be used. And whenever this non-difficult airway, intubation is attempted and it is not possible, again there is an option for adjuncts, and in case of failure you have to proceed with the surgical airway. That's why in evaluation I stressed upon, whenever it is difficulty in surgical airway, you have very limited choice. So it becomes really difficult when the tracheostomy is also very difficult, like a huge neck trauma patient coming with a huge thyroid swelling. So your plan has to be properly determined. Okay, and you have to always keep in mind that these patients may have raised ICP, they will have, most of them may have cervical spine injury, and they may be in varying degrees of shock. Coming to airway injuries, so facial-maxillary injuries and penetrating neck injuries. Per se, in these patients, avoid sedation if patient has presented to you in a conscious state. Immediate intubation of airway is indicated before it gets obstructed, and retrograde intubation and blind nasal intubation choices are not possible in these patients. So before the patient obstructs, you have to secure the airway. Consider awake techniques. Avoid positive pressure ventilation proximal to the airway disruption. Avoid or minimize cricoid pressure as it may further damage the damaged trachea. Avoid blind insertions of nasogastric tubes, and all intubation attempts in OR should be done in presence of surgeon with tracheostomy standby. No nasal intervention in skull base trauma. So this is one patient which presented to our emergency room with cutthroat injury at 2 o'clock in the morning. Our residents, they secured the airway, whatever trachea was available with the endotracheal tube. You can see that spontaneously breathing patient, so patient was kept on TPs, and with surgeon's help, the tracheostomy below the level of neck injury was secured. Surgical airway, I suggest we should master this skill as an anesthesiologist whenever we are working in trauma. So transtracheal jet ventilation, surgical or needle cricothyroidotomy or proper surgical tracheostomy can be attempted in appropriate patients. And maintaining the neutral position and USG assistance in all these cases. We are routinely using USG for all the airway assessments, IVC cannulations, and all the whatever the earlier lecture covered, we are all doing it for our trauma patients. These are commercially available sets, which are cricothyrotomy sets, which use Seldinger technique. They are very easy, can be learnt by anesthesiologists. So when you have unconscious patient for emergency intubation, we discussed that head and neck suspects head injury and cervical spine injury. Focus on adequate oxygenation, manual inline stabilization, maintain the neutral position. Usually 3% technique is required. Consider patients as full stomach and modified rapid sequence or rapid sequence induction for all these patients. Wherever patient is awake and patient is coming up for emergency intubation, we can proceed with drug assisted intubation with cricoid pressure. So the choice of anesthetic agent will depend upon whether patient is having raised ICP or patient is hemodynamically unstable. Patients with raised ICP, thiopentone and propofol in graded doses can be used. Remember, patient may be in varying degrees of shock, responder, non-responder, whatever it is, you have to reduce your total dose of induction agent. Give it in a small titrated doses, which is after seeing the clinical response. In unstable patients, ketamine, etomidate, multiple trials have been done. Fentanyl can be used safely, but keep IV fluid bolus ready and keep short duration or short acting vasopressor ready just in case the mean arterial pressure falls below the acceptable level. So small incremental doses and avoid large tidal volume ventilation. When you are ventilating the patient, that will reduce the venous return and you can immediately see the changes of hypotension. In shock, usually no drugs are recommended in grade 3 or 4 shock. And relaxant of choice, succinylcholine and rocuronium, anything can be used. Majority of the times we are using succinylcholine for its advantages of shorter duration of action. So drug assisted intubation, they were found to be safe in outside OR also. Coming to breathing, patency of airway, breathing effort and status of gas exchange. When you are evaluating, you have to see that at what level your patient has, what is the level of oxygenation, ventilation, and what is the X-ray and ultrasound findings. So most commonly you may get patients with flail chest, hemopneumothorax or tension pneumothorax. So patients with multiple rib fractures, they will have paradoxical movements. So while shifting, usually the ICD which is in situ is clamped and the patient is coming on table. Many a times we did not realize, or the surgeons did not, they don't realize that we have to release that clamp. So patient, when it comes to table, there may be sudden changes related to that. We have to look for the output of the ICD, the column movement, and you have to hang it properly below the level of the heart. These patients may have underlying lung conditions. So now patient may appear stable, but post-operatively, these are the patients who may require prolonged post-operative ventilation. And do suspect spinal injuries whenever these flail chest patients are there. These are the patients who require analgesia for prolonged duration of time for proper breathing. In patients with pneumothorax, again, prior to giving IPPV, please ensure that the intercostal drainage is in situ and properly working. And for tension pneumothorax, needle decompression is to be done, ultrasound, excellent modality available. So do not wait for the X-ray to document this big pneumothorax. Till this time, the patient will present to you in shock with hypotension. Hemothorax, again, the blood replacement, we have to focus, and mechanical ventilation may be required in these patients. Shock, it is to be presumed due to hemorrhage until proved otherwise. So the source of the bleeding, source control, whether it is adequate or not, whether the IV access is in place or during shifting it has come out, what is the size of the IV access, and details about the IV fluids received, blood transfusion received, and whether patient has received any vasopressors during the time of resuscitation. This is to be noted. Circulation assessment is to be done clinically as well as CNS, skin and urine output. These are the 3 windows where the shock will be evident. So we have discussed this hypovolemia as told by Dr. Manish, that class 1 hypovolemia, everything may appear near normal, but by the time the patient develops hypotension, it is already patient has progressed to class 3 and class 4. And yes, we do give anesthesia care inside the OR for damage control resuscitation and damage control surgeries. We do provide analgesia and anesthesia services. So majority of the patients who come for damage control will be in class 3 or class 4 hemorrhage. So their shifting from the ICU to the OR, everything becomes problematic. Vigorous resuscitation will lead to hemodilution and increased bleeding, and it may lead to recurrent hypotension. So we have discussed this concept of permissive hypotension, that delaying massive fluid resuscitation till the time the surgical control is achieved. So restoration of radial pulse, restoration of mental function, and SBP target of 80 to 90 is to be maintained throughout the resuscitation as well as till the time the surgical bleeding is controlled. And in head injury patient, we have little higher targets of systolic BP of 110 and mean arterial pressure of 80 mmHg. So our assessment goals focus on knowing the resuscitation status, airway assessment, just compilation, identifying the comorbidities, identifying the sepsis, noting down the investigations, informed consent with ASA risk and formulation of the anesthesia plan. What all investigations which usually we look for is blood grouping cross matching, because patient may need to activate, we may need to activate massive transfusion protocol, complete blood counts, renal function tests and coagulation profile. Serum electrolytes, very important, ABG and lactates to guide the resuscitation as well as to avoid the lethal triad. Sugars, LFT, ECG, according to the patient demands, we do investigations. 2D ecography, thoracic ecography is one of the technique I recommend strongly that we as anesthesiologists should be mastering, because simply by having a cardiac probe in our hand, majority of the cardiac problems we can identify and we can rectify in time to avoid the mortality. So in our institute we are routinely practicing this transthoracic echo where the cause of hypotension is unidentified. Even for routine evaluations as a training purpose, we have incorporated this in our practice. X-ray may show pneumothorax, fracture ribs, gas under diaphragm, consolidation, or patient has already aspirated and come to you. Patient may have ARDS-like changes or patient may have COVID changes. So these are the challenging patients to manage intraoperatively and postoperatively ventilation-wise. So other X-rays available, if available, do look at them. And investigations, other investigations, these patients keep coming and going to emergency room, to radiology suite for angiography, therapeutic or diagnostic or CT or MRI. But before shifting the patient, make sure that your primary survey, secondary survey and resuscitation the goals are achieved. And all the time, whenever during transport, do not disconnect oxygen and cervical spine stabilization has to be maintained. Pre-operative preparation includes, as per the protocol, the antibiotics to be given, anti-aspiration prophylaxis, avoid sedatives in depressed patients, and warming the patient actively is very important. Basic monitorings, ASA standard monitorings is to be included for all the patients. However, depending upon the trauma, like suppose a cardiac stab comes and that patient is to be taken up in your emergency OT, you have to escalate your monitoring standards. So invasive lines, your base and temperature has to be a routine protocol, but depending upon the case you have to modify your monitoring plan. Choice of anesthesia can be anything, general, regional or local, depending upon the hemodynamics of the patient, site of surgery, diagnosis, presence of coagulopathy and presence of sepsis or shock. Majority of the times we do give general anesthesia in emergency for all these patients, but yes, regional anesthesia also can be considered for isolated limb injuries. So we have lot of advantages with general anesthesia, as we can exactly titrate the duration, we can maintain the positive pressure ventilation, and simultaneous procedures can be handled better. Regional anesthesia also has its own advantages of having early recovery and better pulmonary, decreasing the pulmonary complications. So regional anesthesia in the form of spinal anesthesia, epidural or peripheral nerve blocks can be considered. Please be aware of the fact that whenever a patient with bilateral traumatic amputation comes to you, spinal anesthesia is not the choice, because patient has had a massive shock. Your BP may be, target may be achieved 100, but still patient is in that recovering stage of trauma and injury. So immediately when you see the patient with traumatic amputation and the orthopedician wants to operate, assess the patient properly before giving regional anesthesia. On arrival blocks, we are using in our trauma ward landmark guided, PNS guided or mainly USG guided blocks we are giving. There is a detailed lecture by Jana sir on this. So I'm not going into details of it, but yes, by providing adequate pain relief, we are using lower concentrations, lower volume of drugs whenever we are using USG, that is the advantage. By providing analgesia, the further evaluations are becoming easy. The investigations, the radiology and the transport, everything becomes easy when you give on arrival blocks. However, whenever your patient is having one of these, you are not going to proceed with the regional anesthesia. You have to remember this, that hemodynamically unstable patient with shock, patient with coagulopathy, spine injuries, raised ICP, uncooperative patients and infection sepsis. These are the few contraindications for giving regional anesthesia in trauma patients. Coming to general anesthesia, pre-oxygenation has a very important role, and you have to do it authentically because you are going to do a rapid sequence induction. And adequate pre-oxygenation is going to give you some extra time for your intubation attempt. So do not skip this step. Pre-induction, identify the cricoid cartilage, maintain manual inline stabilization in suspected cervical spine injuries. Short-acting opioids like fentanyl we are routinely using. Small incremental doses titrated to clinical response is to be given for these patients, along with ongoing volume resuscitation, and vasopressors are to be kept ready. So what happens to these anesthesia drugs in shock? In shock, there is decreased volume of distribution, higher plasma concentration of drugs is achieved. So there is more rapid onset and more profound effect. So as less as only 10% of the drug can give you the similar effect. So it has to be given in a titrated manner with rescue vasopressors standby. Choice of induction agent for rapid sequence induction. Patients, roughly I have divided, patients who are euvolemic and blood loss less than 10% of volume deficit, we can consider propofol and thiopentone. However, hypovolemic patients with say 10, 20 or more than 20% of volume deficit, etomidate and ketamine should be considered in graded doses. They also can lead to hypotension. Etomidate, it has been recommended as a ATLS protocol, in ATLS protocol, single dose for trauma intubations. However, we have to keep in mind the side effects, mainly the suppression of adrenal cortical synthesis in prolonged infusions. The neuromuscular blockers, we are routinely using dexamethasone in the dose of 1 to 1.5 mg per kg. It is helpful in anticipated difficult intubation because of shorter duration of action. However, it is to be avoided in patients where we have raised ICP, raised potassium, crush injuries, burns injuries and spinal trauma. Rocuronium again is a good alternative to dexamethasone, and nowadays the immediate reversal with Sugammadex is also possible. So whenever inside the OR, whenever you are encountering difficult intubation, call for help, maintain oxygenation, 10 to 15 liters of nasal O2 during procedure, optimize the position, external laryngeal manipulation, release or you may have to reduce the cricoid pressure. So when you are doing that, go for gentle mask ventilation if at all you are doing modified rapid sequence induction. Use alternative technique like bougie, Stilett, McCoy or video laryngoscopes, and alternative plan with second generation SGAD or front of neck access has to be ready. Coming to maintenance, again I am stressing on the careful titration of all the drugs is very important. Avoid nitrous oxide in presence of air cavities because they may expand and exaggerate the effect of pressure effects and hypoxia. Inhalational agents are to be titrated because the MAC of inhalational agents was found to be less reduced in shock and severe sepsis. Maintenance goals, you have to avoid hypoxemia at all the stages. Target PCO2 is 35 to 40 mmHg, and wherever you are suspecting that patient is having underlying lung contusion, lung trauma, aspiration pneumonitis, so you have to institute lung protective strategies with low tidal volume inside the OR itself, with or without PEEP, depending upon whether the patient is going to tolerate it or not. IV fluids, we have had enough discussion in the morning session, but I would like to stress on avoid glucose containing points, or whenever you want to give glucose containing point, monitor sugar. Limit the use of colloids. Permissive hypotension targets are to be maintained, especially in traumatic brain injury. You have to maintain little higher targets. Vasopressors and inotropes, as per European guidelines, are used only when there is life-threatening hypotension and myocardial dysfunction. Analgesia, another a very important part of these trauma patients, and often it is under treated because patient may not be in state to tell you that he is having pain. So most of the times it is under treated, but multimodal analgesia options has to be provided to the patient for better postoperative and intraoperative course. So shorter acting opioids, tramadol. In chest trauma patients, we are also using buprenorphine, IV, IM or epidurally. Non-opioid analgesics like paracetamol we are using for almost all the patients in trauma, and additives and peripheral nerve blocks can be considered. Intraoperatively, what all problems overall your patients may face is they may have blood loss, hypotension. So availability of the blood, cross-matching, titration of the vasopressors, your infusion pumps, everything has to be checked. Dilutional coagulopathies and transfusion reactions are not uncommon. Acidosis, patients may have acidosis and electrolyte disturbances. They have to be corrected along with hypothermia. Patients with crush injury may have, or patients who have undergone angiographies because of the radiocontrast dye, they may present with acute renal failure. Awareness under anesthesia again can be a major problem. Whatever is the your institutional protocol for transfusion of blood products, you should be clear about the transfusion protocols, and we should monitor the lab parameters intraoperatively also to avoid coagulopathy. So platelet concentrates, FFPs and cryoprecipitates are to be replaced early to prevent the coagulopathy. Along with massive transfusion protocol, now we have a massive hemorrhage protocol also coming in place. So soon we will be having our Indian massive hemorrhage control protocols. This is from one of the Canadian Journal 2019. Rapid infusion systems may be required in patients who are having a massive hemorrhage, and alternatives to blood transfusion like conservative strategies, blood conservative strategies, or recombinant factor 7A, tranexamic acid, fibrin glues, thrombin glues, and minimally invasive surgery wherever possible is to be instituted. Tranexamic acid, the role is very clear for after the CRASH 2 trials. It has been shown to reduce the rate of bleeding and improved survival rate. So the dosing options, we have 3 options. We can give 1 gram bolus dose followed by 1 gram infusion or over 10 minutes. Or if you are considering the transfer of the patient, you can give immediately 2 gram bolus. However, the dose has to be given within 3 hours of injury. So trauma, little bit about trauma-induced coagulopathy. Complex, this is very complex and multifactorial etiology with higher incidence and poor prognosis. So we discussed about lethal triad of coagulopathy, which is dangerous. However, when it is accompanied with hypocalcemia, it becomes the diamond of death. So lethal triad as well as diamond, both are to be avoided intraoperatively, perioperatively, in ICU, wherever you are dealing with your patient. How to prevent it? Permissive hypotension, early transfusion, early use of plasma and platelets. There are many trials supporting the early transfusion in the ratio of 1:1:1. And if this is, this also has to be guided by goal-directed transfusion therapy. Extubation is to be considered whenever the patient has been adequately fluid resuscitated, blood is replaced, adequate analgesia is provided, correction of hypothermia is done, he is breathing spontaneously and awake, then only you can consider extubation after adequate reversal. However, patients who are geriatric, hemodynamically unstable patients, presence of sepsis, organ dysfunction, these are the poor predictors of outcome. So they may require post-operative ventilation along with these other parameters. Post-operative care should involve a multidisciplinary approach inside the ICU. So you have to address the analgesia, ventilation, hemodynamic support, paralytic ileus prevention, antibiotics, nutrition support, physiotherapy, DVT prophylaxis and ulcer prophylaxis. So coming to
Hello,
in short
time is up.
yeah,
madam.
yeah. Coming to specific injuries, just four more slides I have. So you have to consider head injury whenever you have head injury patients coming to your emergency early airway management, avoiding hypoxia, avoiding hypotension, adequate ventilation and maintaining hematocrit along with your ICP management is very important. Head up position, anti-edema measures, anti-convulsions are the routine protocol. But wherever you cannot monitor ICP, we can see the optic nerve sheet diameter and we can predict that the patient is having raised ICP. So primary brain injury actually it does not cause shock, but the shock may cause secondary brain injury. Similarly, for spinal cord injuries, patients may present to you in neurogenic or spinal shock. So, maintaining the hemodynamics, adequate cardiac output, along with some steroid is the mainstay. Abdominal and pelvic injuries, mainly the external fixators and pelvic binders is important. Whenever you are securing IV, avoid IV access on injured limb, and in case of fracture pelvis, avoid the IV access on lower limb. Invasive monitoring, availability of the blood products again has to be confirmed, and damage control surgeries is the mainstay in management of hemorrhage for abdominal and pelvic injuries. Post-operatively, these patients may have abdominal compartment syndrome. For musculoskeletal trauma, patients may present to you with extremity fractures, amputations or crush or compartment syndrome. Remember that these patients may have dangerous hyperkalemias, arrhythmias, acidosis. So avoid use of scoline and nephrotoxic drugs and be cautious with your regional anesthesia. Special population, pregnancy, pediatric and elderly patients. The pregnant patients, because of their altered physiology, they tolerate greater blood loss. So the signs of shock are not evident. Radiological investigations has to be done whenever with abdominal shielding, and fetal monitoring by gynecologist is to be instituted. Pediatric patients, they usually have low functional reserve, poor tolerance to blood loss, and they are prone for occult internal injuries. So that has to be remembered. Elderly patients, as we discussed, they are on polypharmacy, beta blockers mainly. So the compensatory mechanism to shock may be absent in these patients, and because of the hearing defects or hearing abnormalities, the assessment and the history may be difficult. So whenever these patients, we are addressing these patients outside OR, our principles remain same of ongoing resuscitation, maintaining oxygenation and perfusion, preventing the secondary injuries, reassessing the airway and maintaining the cervical spine stabilization. So these are challenging cases. Technique keeps on evolving. These are dynamic situation all the time. So individualizing the choice of anesthesia as per patient's needs is very important, along with the multidisciplinary approach. Thank you very much.
Thank you, madam, for such a nice and informative lecture and sharing your experience and knowledge with us. It's really difficult to cover all the topics, but you have touched all the aspects of anesthesia very nicely. Because of the time limit, we may be taking the question answer session at the time of panel discussion.
Yeah.
Thank you, madam.
Thank you.
Yeah.
Thank you very much.
Thank you.
I request Dr. Hemani Madam to felicitate Hemani Madam and Dr. Manohar to felicitate Dr. Deepali Thakur. I request Dr. Priyanka Rathi to felicitate Dr. Hemani Madam. I request Dr. Vilas Mayode sir to felicitate Dr. Manohar Mane. Thank you, madam, for your wonderful talk. We are heading about to our next session.